Well, good afternoon. We're going to let people start to come in, and once we settle, we will get started here.
And Alfred, you'll watch the chat for me.
Yes, I will.
If
Yeah,
there's a question that comes up, if I don't see it, I don't know if I'll see the chat or not. If I
okay,
don't, feel free to interrupt.
we'll do. Yeah,
Yeah. I'm sorry. Feel free to let me know. It wouldn't bother me. There you go.
okay. All right, sounds good. All right, just a couple more minutes. I know folks are coming back from lunch, so we'll have people filtering in for the session. But how about so that we can maximize the use of the time, we'll just get started. So, welcome to this afternoon session, Fall Response to Patients with Head Trauma and Long-Term Care. I'll be serving as the moderator. For those that don't know me, my name is Alfred Johnson. I'm the MIPIN Vice President, and we are pleased to welcome my friend, Dr. Dan Hanowitz. He's a geriatrician in solo private practice and a multi-facility medical director who specializes in long-term care. Dan is the chair of the Paul Med State Advocacy Committee, facilitator for the National Assisted Living Delphi Group, and a member of the Pennsylvania Long-Term Care Council. He is highly rated speaker at national symposiums, and we are delighted to have him presenting with us today. So, welcome, my friend.
Thank you, Alfred. Always nice to see you. Hi, everybody. So let's get rolling. Here's what we're going to be talking about this afternoon. We're going to be talking about fall response, which is not as common a talk in falls versus prevention. Something about how staff in long-term care does an assessment. A big question is whether you tr move somebody to the emergency department or not. I don't think you can give a fall talk without discussing liability, but I do hope that the opportunities and take-home points will provide you some value. Now, when I was developing this talk, it's funny how much this has to do with this sweatshirt that I bought my wife, like, I don't know, 20, 25 years ago. It's the big questions. And I'm sure Alfred thinks about these sort of things all the time, right, Alfred? Who am I? Why am I here? What is my fate? And where are the cookies? Right? So those are the big questions. So who am I? Well, Alfred just told you who I am. Why am I here? Well, this talk started up, Paul Med, the Post-Acute Long-Term Care Medical Association, used to be AMDA. So when it says AMDA, they had a forum, and somebody asked a question, hey, neurochecks in nursing homes is very cumbersome. What's the best way to do it? So I got an email, and this is like, if you take anything from this talk, if somebody sends you an email and says, hey, we want you to do something, you're the perfect person for it. It usually means they're asking for a lot of work. So really think carefully about this. So since they were like, stroking my ego, I said yes for this article that could use my expertise. And it wound up in the Caring for the Ages. There is the link. We'll get this later. I think you're going to get a copy of the slides. Heads up, considerations for falls with minor head impact in long-term care. So that's sort of why I'm here. The other reason why I'm here is because Alfred asked me to. Um, I think we met in the California Long-Term Care Medicine. They had a COVID Delphi group, which the Assisted Living Delphi spun off of. I did a talk with Alfred in the Wisconsin Paul Med chapter. I've been involved in the Quality and Assisted Living Collaboratives, one of their work groups, and I'm hoping that Alfred also will work with our fall response project, which we'll get to at the end. So that's why I'm here. Now, this is a picture of Lower Bucks Hospital. Uh, Today is the latest talk I've given that you guys should know this. The very first talk that I gave in public was in like 1987 at Lower Bucks Hospital. As a tangent, I was supposed to give this talk last year, but it was actually a patient at Lower Bucks Hospital for I think it was a med interaction. And I think one of those windows that you see was where my room was. And I was sad. I wanted to still give the talk. Alfred, I think I offered to give it from my hospital room, but it just didn't feel right. And I actually didn't feel right, come to think of it. So I was hate to disappoint you guys from last year, but this is the deal. So anyway, so I give my first talk in the late 80s at Lower Bucks Hospital, and those were the days. And it's in a room full of white men, white-haired white men. So I give the talk because that's how it was. All the old white doctors came to the talk. So I give the talk, and one of the white-haired old doctors comes up to me after and says, "Wow, what a what an amazing talk that was. You're incredible." I said, "Thank you." He says, "No, you radiate waves of intelligence." I go, "Thank you." He's like, and you project, you talk loud, which is, important with the old white guys, right?" He says, "Look, I've been coming to talks at Lower Bucks Hospital since like 1954, and I have never enjoyed a talk as much as the talk you just gave." This is a true story, by the way. And I said, gosh, that is such kind words. Thank you so much. Uh, I'm really appreciative. But don't you think maybe you're just a teeny little bit biased, Daddy? So my dad, Alfred, have I ever told you this story? Have you heard this story before? Yeah, this is true. So it was my dad, and I love a joke where the kicker's in the very last word, But anyways, it's not a joke everybody can use. Um, but my point here is what is my fate is that if you enjoy this talk like 20% as much as my dad would have, 10% as much as my dad would have, I think we'll be doing okay. And as far as where the cookies are, I guess they're either in your laptop or in your pantry. So I answered the four big questions there. Okay. So who am I? Who are you? Um, Alfred, this is our poll question. I just like to know it's a little too late for me to gear this talk specifically to who you are, but I would still like to know who you guys are. I think that's polite. So if you could go ahead and pick your question, we'll give it what, 30 seconds, Alfred? A minute? 30 seconds, I think is plenty. Look, even if you're shy and you don't want to say, that's okay. But we're kind of testing out the poll question thing because I have a better poll question for you later. So, okay. Alfred, so you can't vote. All right.
Uh-oh, yeah.
Yeah,
All
just
right. So
making that
I will
clear.
end the poll now
And see what we got.
and share the results.
Okay, we are researchers, intervention professionals, nurses, and okay. So like basically a quarter of each. Well, that's great. Terrific. Well, I hope this talk helps you. All right. So, moving along, I hope. Okay. I can't get to the next slide. There we go. Okay. So here's our objectives. I'm going to talk about the current literature on fall response, talk about some of the rules that the emergency department will use on whether when you should do brain imaging, talk about neuro checks, and really try to talk about what best practices and maybe poly procedures. Our goal here is how can you minimize hospital visits that aren't needed and also individualize your care to residents so that you're actually aligning with their goals of care. I have no financial disclosures. So here's clinical scenario number one. We have an 80-year-old white male. Let's call him Mr. B because his last name does start with B. He lives in an assisted living memory unit. He falls. He goes to the emergency department. His vital signs are pretty good. He doesn't have a fever. His pulse ox is good. They can't really get anything from him or really do a good physical exam because he's very confused. There are his labs, blood sugar a teeny bit, his creatinine is a little bit up, so it says something about the kidneys, white count's normal, and his urine shows 1519 white cells and too numerous to count red cells. And here's his CAT scan, which essentially doesn't show much. So, let's see. The poll question is, what is the result of this visit to the hospital? And I think, Alfred, I can. So 1A, he's admitted for sepsis. B, he's given intravenous fluids for his acute kidney injury. C, they send him back to the assisted living community with antibiotics for a urinary tract infection. D, they send him back with antibiotics for pneumonia. E, they send him back with no changes at all. And F, an angry Dr. Haymans calls up the director of the emergency department. All right, roll this poll. That rhymed, Alfred. Okay. So go ahead. Sepsis admission, kidney injury, UTI, pneumonia, nothing. Angry me. Hey, listen, in this poll, you don't even have to be a doctor to give your opinion. I'm feeling it today, Alfred. I'm feeling magnanimous.
Yes, you are. Look at this.
Yeah.
F is leading the
All right,
cause.
let's
Yeah.
see. Okay. So what are the answers?
You see the leading answer you see is F.
I don't see that. I don't see that.
Uh,
So what did people say? So F was
so
leading
yeah, you have F is leading at 50%.
uh,
It looks like C discharged back to
for the
the
UTI,
community, yeah, with the
right?
UTI.
Uh,
There's 8% sent back with the PNA, and
uh,
then 8% sent back with no changes, and
okay.
then IV. So
Okay. Okay. So it was some degree a trick question. The answer is okay. I think my computer freezes a bit after these polls, Alfred. Come on. Come on, baby. Let's go. Hmm. All right. I can't. Okay. There we go. So the answer was D. He was sent back to the assisted living with antibiotics for pneumonia because what I didn't tell you was that the chest x-ray showed a, quote, small area of infiltrator atelectasis left lung base, mild atelectasis right lung base, followed by x-ray. So what they did was after he was sent with a fall, he went to the emergency room and they treated a chest x-ray, not the patient, who remember did not have any signs of hypoxia, didn't have a cough, didn't wasn't short of breath, had no symptoms, but they treated him for pneumonia. But, and you're right. They 50% got it, Alfred. I was pissed off and I called up the emergency department and said, "What are you guys doing? You're actively harming my patient." But I've chilled out. I was much more stressed those days. I feel better now. So anyway, there you go. So let's see. So next, okay. I'm sorry. So I don't know if you guys are familiar with um, Interact or interventions to prevent acute care transfers. And this is the care path for fall. And if you look at it, you'll see that a lot of it is evaluation. But this box here, the initial nursing evaluation for injury. And I think a lot of these are pretty clear, but it doesn't really go into depth into what we're thinking about. Now, as far as evaluating the results, urine results suggest infection. You know, my peeps in long-term care, we all laugh about how everybody has a urinary tract infection when they go to the emergency room, which we don't even laugh about anymore because it's just awful, awful antibiotic stewardship. Um, so the key to this talk is, what do we do after fall and, you know, managing in the facility, all right? Now, if you look at the Interact, there's a Interact for long-term care, there's a separate Interact for assisted living, and they have some literature there. And the problem with it is that it's not specific to head falls. And the second one, which I'm not saying is not good research, though, is also all falls. But was their model was that the paramedics would speak to the physicians and make a mutual decision whether to send somebody to the emergency room or not after a fall. They had a company editorial to that, which basically said why that's maybe not doable in the real world. Because how it really works is most of the time for me is either I'm called after the fact, say, Mrs. Smith fell, we sent her to the emergency department, or I'm not even told at all. So, some research is hard to apply in the real world. So the scope of this problem, obviously falls happen a lot in the elderly across healthcare settings, but the highest rate is in long-term care, more than 3 times in the community. Half of residents experience a fall more than once a year. And mortality, now the research is in males, was associated with how many falls they had. and the numbers that involved head injury. So head impact is, an important part of this. The literature has no consensus guideline. There's not a best practice as to what to do when somebody falls, particularly when you don't know if they fell, if it's unwitnessed, or it was a low impact fall. Third of fallers hit their heads, and there's conflicting evidence. We'll talk about this. Is who's at risk for a bleed, how large the risk is, um, but clearly there's potential harm with sending somebody to the emergency room with the risk of getting inappropriate medications. People with cognitive impairment can get more confused. They might get inappropriately hospitalized. The cost to patient and family, there's a lot of problems with that. So it would be nice to avoid that. So what's the question? Is the question when a patient falls in long-term care, who either hit their head or I don't know whether they hit their head, should I send them? Or if you kind of like twist that question, it's in what circumstances would the emergency department feel a workup is necessary, right? Because if the patient doesn't need a workup, like if there's things that you can do in the long-term care setting, why send them in the first place? Which I don't think is a view of this that we commonly think about. When patients with falls come to the emergency department, they get CAT scans, and at least a third of them, according to guidelines, shouldn't have been ordered. The vast, vast majority, like Mr. B, you get a CAT scan, 90% of them have no significant findings. So there have been specific rules developed to say, and this is not for long-term care, this is across the entire population, uh, when should you do brain imaging? And I'm going to go through these quickly because there's multiple ones. There's the New Orleans rule, and there's a couple details here. I've included the links to all of them in the slides. Suggest that when older age is the only risk factors, they should do it. The Canadian trauma rule, uh, with older age, can't rule it out. Um, they don't actually specifically discuss about blood thinners. The Nexus tool, same thing. Uh, they say it's safe to not do one if all eight criteria are absent, but one of the criteria is older than age 65. So it rules this out, kinda, for elderly patients. And the National Institute for Health and Care Excellence. So there's multiple rules. Do they fit into the elderly population? Well, the American College of Emergency Physicians talks about these scales. They mention that all four use the Glasgow Coma Scale. That's something that you'll see a lot in the emergency room. We don't really use that in long-term care at all, and we will talk about this. Part of the issue of using a Glasgow Coma Scale is that if you have baseline dementia or any other kind of cognitive impairment, it may not work as well. Um, so these may or may not be specifically applicable to older patients. So maybe a better question is to look into is what does your emergency department use? Or actually, does your emergency department even use one of these, right? How does a individual emergency department physician make their decision? In my experience, it kind of varies from physician to physician in the emergency department. But still, you won't know what they're doing unless you ask them about it. So after I gave this talk, I got a couple excited texts, as much as a text can be excited. Hey, hey, hey! There's a new article out specifically about geriatric head trauma when to use a CAT scan. Wow! Right, great. So that came out in September 2024. My article was in June, July. It was from Dr. Shi. It was also with Dr. Auslander. Dr. Auslander is brilliant. He's from Florida. He was the physician who spearheaded Interact. So I'm like, okay, great. So they say that you have all these clinical decision rules, and this is what they said in the article: none are applicable to geriatric patients. So what I just said, at least two aren't. They felt none of them are. All right. So what they did in the study was they gave points, and if you have greater than 25 points, you should get a CAT scan of the head. All right. So here's some of the predictors, what your Glasgow Coma Scale is. If you're on antiplatelet, not Coumadin or the NOACs, the Eliquis or the Xareltos, some other things, signs of fracture. So here's the biggie. And if you arrived to the emergency room via an ambulance, that in and of itself, 30 points says you need a CAT scan. What the heck? I thought maybe they were punking me. So I actually called up Dr. Shi and I said, are you joking? Really? Um, doesn't this kind of invalidate the whole thing? Now, if we want to try to make uh, our country a better place, I was giving this a talk in my home state, and I came with this great idea that maybe we could get this like cadre of retired physicians and have them drive their cars to the nursing home and the assisted living communities to pick up people who fall. Don't you think it's a great idea? Yeah, Alfred, it went over big. I'm telling you, big, big, big. Now, interestingly, in this study, they said while antiplatelet therapy is the clinical decision model, anticoagulation was not a risk factor. So Dr. Shi says that this corroborates the findings that there's no increased risk of intracranial hemorrhage if you're on blood thinners prior to a fall. It doesn't seem to make sense, right? But don't shoot the messenger. I'm just telling you this is what the data shows, okay? So our inconclusive conclusions are that there's conflicting evidence about this. So some people say if you have a suspected or confirmed head injury and they're not on blood thinners and they don't have symptoms, signs and symptoms of a concussion, then you don't need a CAT scan, which would mean you wouldn't need to send them to the emergency room in the first place. But then somebody else says it's advisable to scan every older patients with a minor hand injury. So in the long-term care setting, there are no definitive guidelines. So I give this talk again to my peers, and they go, boy, what a terrible lecture this is. Can't believe people tell me these things. Like, you're not telling us what to do. I said, I'm not sure you're super paying attention here, okay? That's not the point I want you to get out of this. My point is that there are not conclusive best practice about this, so you don't have to send everybody who falls, with a head trauma or not. You don't have to send them. The literature does not back that up. Okay? So that is the mind frame I want you to have, that the evidence is not clear about this, so you're not forced into doing something that either you don't want to do, you don't think you should do, and most importantly, we'll get to this, the patient and or the family don't want you to do. Okay? So let's talk about the big fear, which is okay. Everybody says, well, you're on a blood thinner. It means you automatically have to go to the emergency department. Well, Dr. Shi said that a high enough risk warrants imaging in all patients. Now, this is a study from 2020. His Florida fall thing was 2024. Maybe he's changed his mind, but certainly the rate of bleeds when you are 8 times higher when somebody's definitely hit their head versus you're not sure. Okay. Some people say anticoagulation makes the risk worse. Some don't. Like, look at the fourth bullet point. Um, one study said that patients on oral anticoagulation like warfarin, Coumadin, the risk of bleeding in the head was not significantly different than people not on anticoagulation. The other people have found some no association between anticoagulants and intracranial hemorrhage risk. So, you know, what about baby aspirin? Because some people include baby aspirin and say, oh, they're on baby aspirin. We should send them to the emergency room. Again, there is not conclusive evidence. So, which again, I'm not sure that means you definitely, without question, have to send somebody to the emergency room if they're on blood thinners. Look, I know and we'll talk about one's comfort with risk. This is just what the data says. Okay. So people say, oh, let's do neurochecks. Neurochecks, they're the best things ever. Well, I don't think they actually are the best things ever. Every time I see this picture, though, of shining a light in somebody's eyes, for some reason, I don't know why, it makes me think of my cat. I don't know why. And then if I see my cat, I've got to include a picture of my dog. That was Lizzie, this is Ella. Um, and it's a well-known fact that talks are always better if you have pictures of pets or babies in them. So, Alfred, I hope you agree. So, anyway. Neurochecks. So what are the questions? How often do you do them? That was what started this whole talk. How long do you do them for? What's included in a neuro check, right? I think there's an opportunity to perhaps do better. And should you even do it? Should you even do neuro checks on somebody who's on palliative care, on somebody who's on hospice, somebody who has a do not hospitalize order, right? Because why should you do something if there's not going to be any action based on what you're doing, right? This is not an action and an equal reaction. If you're not going to do anything, why are you getting neurochecks in the first place? So think about it. Like all these things, there is uncertainty. There's no best practice, okay? Even in hospital intensive care units, I know these are older studies, but there's nothing newer. Nobody really knows, can say with certainty, this is what the research says is what should be included in a neurocheck, how often you should do it, and for how long you should do it. Now, certainly, I think, and we're going to talk, we've already talked about this, signs and symptoms of a concussion would lead that. And of course, there is risk of getting head bleeding after a fall. Now, I'm not saying don't do neurochecks. I gave this presentation, and this attendee ripped me to shreds, telling me, "You're wrong. You're so wrong." Which was nice in a way. For an instant there, I kind of felt like I was at home. You know, always being told I'm wrong, never being right. Um, but I sort of challenged her a little bit, saying, look, I'm not saying your organization doesn't do a good job. Okay. What I'm saying is that there isn't data that backs you up when you say I'm wrong, you're right. You show me the data that says there is a nationally known things to put in neuro checks, how often and for how long. And of course, she didn't answer because I'd already looked it up and there isn't one. And I've asked people much smarter than I am. That's just the scoop. A friend of mine had told me something this like 25 years ago. She's like, neurochecks, why are we doing neurochecks? There's no evidence. And there really isn't evidence. What I might suggest to you is to look a little bit into the Glasgow Coma Scale because it's very common in the emergency room. I have the link here for you. Basically, it's can somebody open their eyes? Can they speak? Can they move? Which of course is limited by cognitive impairment. You know what I mean? And a little bit about the pupil reactivity is part of it too. So think about you don't even have to use the words Glasgow Coma Scale if it intimidates people, but you're using the general principles of basically, has there been a change in status of somebody after either a definite or a suspected fall with head trauma? Here's your elephant in the room. I've been trying not to say it to the talk, but I talk about comfort with risk. It's liability. It's hard to give any full talk about falls, but talk about the risk that we're under because that's the scary thing. You know, and I'm not going to assume that, my comfort with risk is your or your organization's comfort with risk, right? I just happen to be looking through the internet. I am not from Kentucky. This is just a typical thing you'll see. And surprisingly, the lawyers like, pound us to bits. You look at this. I mean, it feels terrible. We're negligent. We're abusive. We've assaulted people. Ooh, it's terrible. But there are some bucks here. So, what do you think is the average settlement amount for lawsuits in nursing home related falls? You're getting this poll question going, Alfred? There you go. There's only four, like 98,000, 175,000, 450,000, or 2.5 million.
All right, couple of more seconds with
Yeah, just give a
this.
comment. Yeah, let's do this. I don't think this is
Okay,
these enough. So
yeah.
what did P I don't
So the results we have here are D, or no, C is the highest, 450,000. Next up is D at 2 million, and then B, and then A.
Well, you're correct. The answer is C. 450,000 is the average, but they have gone up as high as 2.5 million. So if the question is, have there been $2.5 million settlements? Yes, there have been. So there's a lot of money uh, that can go here. All right. So obviously, head injuries can kill you if you have a bleed, um, with a lot of money. So the questions here, which we're not going to talk today, is, was the fall avoidable? So did a facility meet their standard of care? But what we're talking about here is, did the facility and practitioner act appropriately after the fall? And I'm hoping that some of the things we're talking about today, I mean, look, I got to tell you, I hope none of you are ever involved with any lawsuits at all. But if you are involved with any lawsuits in falls, it might be worth it to really, really look at your data, right? And say, your actions may be defensible, you know, um, and obviously would a different course of action have a different outcome? So here's clinical scenario number two. By the way, we're done with poll questions, so you guys can relax. Alfred, that means you. So pressure's off. Um, 76-year white male. Let's call him Mr. R. Because yeah, his name does start with R, Alfred, right again. So he has pretty severe dementia, failure to thrive, had a history of a pulmonary embolism, and has dysphagia. Staff calls me up, says he fell, has skin tears, but he's on Eliquis. Ding, ding, ding. We're sending him to the hospital because that's what the facility policy says. And they tell me, quote, his wife is okay with this, unquote. All right. So what to do? Do you send him to the ER? Do you resist sending him to the ER? What do you do? Well, I don't know what you would do, but I tell you what I did. I canceled the trip to the emergency department. Now, this is one of these things where one of my sayings is, at least in long-term care, every day has its own unique set of frustrations. So I'm trying to call the nurses at the assisted living at the nursing home to not send him, but I can't get through. I'm calling up the secretary, the receptionist, get me I need to talk to East Wing. I need to talk to East Wing. And they go, well, they're not available. Well, why aren't they available? Because the staff is sending a resident to the emergency department. No, that's my patient. You know, Jeez. So I did get through. I held it and I called his wife. So his wife wasn't, quote, okay with this. What she was told that our policy here is to send everybody after a fall to the emergency department. She was not given a choice. So not only did she agree with keeping him in the facility, but she said, and I say this all the time, it drives me crazy. Families say, quote, not to be cold, unquote. Well, they're not being cold. They're being reasonable. They're looking out for what their loved one would want. You know what I mean? It's like making care to equivalent with their goals of care, right? That not only would she not do anything if he had a bleed, she was sorry she put him on Eliquis in the first place and wished she'd put him on hospice. By the way, he is on hospice now, because this is an actual patient. But you see my point. You get this all the time where you're not getting the right information until you go right to the horse's mouth about it, and providers, can influence actions. So what I think is really, really important after fall is shared decision making. So when the healthcare provider, the staff, they call the family, what sort of things do you want to say? How did the fall happen? What our policy says, which doesn't mean necessarily you have to do it. It depends what's in your policy, right? The benefits risk going to the hospital versus staying where they are, what you're going to do after the fall, your fall prevention strategies, but individualize this and, of course, document this. To point out, it is not uncommon when people are given a choice after fall to say they don't want to go to the emergency room. Um, okay. So what are the no-brainers here? And this is pretty consistent with what with the Interact. It's obviously if somebody has obvious trauma, they have a change in the mental status, bleeding that you can't control, their vital signs are unstable. They have signs or symptoms of concussion, which is amnesia to the event, nausea, vomiting, dizziness, a change. If you have a family who you just are afraid are going to sue you, or a family that is unsure what to do. If you're unsure what to do, you got to send them. Okay, so these are the obvious ones. But you see stuff like this. This was an article in the Washington Post. Here is the link. And this is specific in assisted living, where this one company's policy was that it doesn't matter the circumstances. If somebody's in a chair and you watch them sliding to the floor um, with um, with no injury whatsoever, they had to send them to nurse. They had no choice. They felt bad about it. what they were doing too was the squads were saying to assisted living communities, "Hey, look, this is ridiculous. We're going to charge you like $100 just for showing up," and the communities paid it. I mean, this is Alfred, maybe something that you can talk about with your vast experience with assisted living. It's an issue. So what I've done, if I did it right, my friend Josh Allen runs a consulting company, and he has a falls policy. This is for assisted living, but I try to attach it to the resources. So if you can see it, um, maybe it's just something to think about. You'd obviously have to get permission from the powers that be. Now, there's more and more technology. Um, there's Safely You. Hope I'm pronouncing it right. There's this other company, Inspirin, who are doing technology that can actually you can look at uh, the details of somebody's fall. So rather than make it an unwitnessed fall, it makes it a witness fall. So it takes out the percentage of people who you didn't know who fell without a head injury. Now, Josh tells me that some states like California have um, have shown that the cost of this, the insurance pays for it because the cost is worth it with the less money you have to spend on unnecessary visits to the emergency department. And here's another pretty picture of technology. Now, I'm not always included in this. Like I was at one of the assisted livings I go to, and somebody had fallen. I'm like, wow, there's this technology out here that we should use. And they go, yeah, we use Safely You. Excuse me? When did you start doing this? And they say, oh, a few months ago. Would have been nice to know, but communication is always a problem, both personally and professionally. So where are the opportunities? The opportunity is thinking about this, discussing it in your organization, so you can cut down trips to the emergency room, and you don't get this unnecessary treatment, the cost, and the hospitalizations. There was a colleague of mine in Virginia who said he saw the article in Caring, and I think this is great. I'm not patting myself on the back. I love this though. He said he went to his facility, he showed them the article, he had discussion. They cut down their number of falls, the number of ER visits after the falls by 75%. Amazing, amazing stuff. So it's doable. You want to respect, above all, the residents' wishes. I think better communication with the emergency department is always good. It could be a challenge. Um, there is, the new technology to look into in an ideal world, what I think the opportunity would be to develop some kind of national standard that supports these kind of rational decisions so that because everybody's afraid of liability. A facility I went to, I took the article, I showed them the numbers, and they still said to me, no, we're not changing our policy that automatically sends people to the emergency department because the state won't let us. Alfred, this is something interesting that from a survey point of view, they said the surveyors won't let us do this. We have to send them. I don't believe that's true. But if we could get something like all get to band together and say, look, we're not saying don't send people who need it, but you don't have to send people who don't need it, right? And again, with many things, there's always a paucity of long-term care specific research. I think this talk is a really good example of it, that there's a lot of unanswered questions. So if we could get really good research to let us know, you know, what we should be doing, I think that'd be fabulous. So the takeaways from this. With a fall, talk to residents and families. What's your process, right? Because if you can have in your policy, we have to send somebody to the ER unless the patient refuses, the power of attorney refuses, it doesn't align with their goals of care, right? Bring up this topic with administration corporate, talk to your hospital, look at your policy and procedures. Is your the amount of time and effort you do your neuro checks, can you make it better, right? To talk about the main thing I think to me is, does a trip out of the hospital align with the residents' goals of care, particularly those with cognitive impairment? Consider your new technologies, and consider joining our little assisted living Delphi group. Oh, our Assisted Living Delphi group. So we meet generally on the fourth Wednesday of every month, but this month because of the holidays. We're meeting next Wednesday, and we're going to be getting Paul Williams. That's, I think, a somewhat older picture of Paul. Alfred's worked with Paul a lot. They are like, he's all jazzed up. They're doing this big project with Safely You. Our idea is how do we get more awareness of this whole response to head trauma in assisted living. So this is an assisted living specific talk. And then Josh, he's to the right, um, who kindly gave us not just in the resources I gave you a policy, but I also gave an in-service PowerPoint that he said I could share with you. So it's next Wednesday, the 17th, 3 p.m. Central Time or whatever time zone you're in. So here I have some resources for you. If you want to hear this talk over and over, it apparently was sent out on ViewMedi, or you could join PulpMed. That would be fine where you have access. Um, this is my email for the AL Delphi group. That's the link for the article. I talk on a podcast, Caring for the Aging podcast with my friend Carl Steinberg. This is a link to the Glasgow Coma Scale. And this is another webinar I did for CalTCM. I hope you guys don't feel like this right now. Okay. I really truly don't. Lizzie and Ella. Oh, hey, Lizzie's here. So I hope you feel better than that. So we have like 5 minutes-ish for questions. There you go.
Yeah.
Okay.
Thank you for that presentation. So if you do have questions, feel free to put them into the chat.
Alfred, should I
And
stop the sharing? I do like the
yeah,
applause.
yeah,
Anyway, all right.
yeah. And if you have questions, please put those into the chat and I'll read them out.
If we don't, I would like your opinion, Alfred, about, you know, their fear that the state won't allow, the surveyors will get you if you haven't sent somebody out with a fall.
Yeah, that's probably an overreaction due to inaction by the provider with no assessment, no care planning, no intervention. And the idea of, person fell and there was nothing done, no evaluation, no assessment. But that's typically what you see is an overreaction.
Right. Right. I agree. I mean, I think that's the thing. You just need to give proper care, right? So, I
Right.
mean, I don't think you necessarily have to be wedded to neurochecks. It's like, are you doing appropriate evaluation for somebody? Has there been a change? You know, um, because I don't think, even if you're afraid of a intracerebral bleed, if they have no signs or symptoms at the time, they may not in the emergency room anyway if they are completely the same. You just have to monitor for them. And the second you see a change, then you act. But
Yeah.
anyway.
And that piece that you mentioned about communication, being able to not only communicate with the primary, but with the family and not communicate an arbitrary policy or what you believe the state or some other entity is saying, but communicating and talking through this. So there's a question that came in. Have you assessed fall response for rural settings where an ED can be a significant distance from a long-term care facility?
Well, I think it's the same issues apply, to be honest. Connie, if you want to elaborate, can attendees speak, Alfred?
No,
Honest-
no.
Okay, so Connie, I don't know if this matters necessarily because it's not as if like when somebody falls, it's a ticking time bomb and you got to get them to the emergency room as soon as possible. If you have a emergency in your facility, right, which could be any kind of emergency, a fall, not a fall. Well, if you don't have the ability to treat them in your facility, you got to get them to the emergency department, right? You know, um, so I don't think, like if you're going to be a long, does that answer your question, Connie? If even though if it may be a long ways away, like an hour ride, it's not as if the sooner you have to get them, if they need to go out, they need to go out, right? And if they don't, they don't. I think it's a particularly good thing to look at not sending people. If you're going to have to send them on an hour trip, right? When the emergency room would say, or you would say, either they don't need imaging or they wouldn't want imaging because they're not going to act on the results of this. You're saving them the cost of an hour, hour ride. You know, besides how long they may be waiting in the emergency room to be seen around here. Now, I'm in a suburban setting, but there are times people have been waiting 12, 16, 20 hours in the waiting room. I mean, it's terrible. So, again, another reason not to send somebody to the emergency department if you don't have to.
Yeah.
So,
All right, so we are at time. So again, my friend, I thank you for this. As I listen and learn from you, I hope others have listened and learned and can take some nuggets away as you work with either settings or individuals or families. One quick plug, MIPIN has a older adult fall committee. We're hoping as that my friend will be able to join that committee. And if you are interested in it, please go to our website, submit. We'll be submitting some things out for year 26 to reestablish and some goals for that. So again, thank you. Next up, we have a break until 1:15 Central Time, and then there'll be two more sessions that will come up, and then a brief break, and then we'll
have a
close
cookie.
and
Have a
have a
cookie.
cookie. Have a
Yeah.
cookie.
I
All
hope you guys found the presentation worthwhile. So, thanks for
right.
having me.
Take care now.
Yeah, thanks
Bye.
everybody. Bye-bye.